Good morning, respected teachers and seniors. I'm Dr. Aishwarya Pun, second year general surgery resident from Union Medical College, Bhopal, and the topic of my presentation is feeding jejunostomy. These are my contents: introduction, indications of jejunostomy, contraindication, techniques of jejunostomy, post-operative management and its complications. Um, So feeding jejunostomy is one of the types of artificial nutritional support. Talking about artificial nutritional support, it is done when the patient is recovering from any kind of major illness or surgeries, and those patients require adequate nutritional support. Hence, we start artificial nutritional support, and also in patients who have inadequate nutritional support for more than or for 5 days or more than 5 days, they require artificial nutritional support. It can be given either um, two ways, either enteral nutritional support or parenteral nutritional support. And enteral nutritional support is always chosen over parenteral nutritional support. And the enteral nutrition is given or delivered into the GI tract directly, whereas parenteral nutritional support is the use of IV route without the involvement of GI tract. So these are the various methods or routes available for artificial nutritional support. This is peripheral parenteral nutritional support, and this is total parenteral nutritional support. Another way, these are the two kinds of parenteral nutritional support. And enteral nutritional support consists of nasogastric or duodenal or jejunal tube support, or either we can also go for gastrostomy tube or jejunostomy tube surgically or via the help of endoscope. And of all, besides these artificial nutritional supports, we can always choose for whole food by mouth, that is oral nutritional support. So the benefits of enteral nutritional support over parenteral route is that it helps in the preservation of gut mucosal barrier, and it also helps in the preservation of immunity of both respiratory as well as GI tract, mainly of the immunoglobulin A, and it also helps in the prevention of gut atrophy. Enteral nutritional support is associated with reduced rate of infection. It also helps in better wound healing, and it helps in the reduction of the total hospital stay of the patient. And it has improved outcomes with regard to morbidity, mortality, and hospital stay. So this is the various benefits of nutritional support. Here we can see, as I mentioned earlier, there will be reduced gut or lung access to inflammation, and it maintains the mild tissues, and it helps in the production of secretory immunoglobulin A at the epithelial surfaces of both respiratory as well as GI tracts. It helps in the increase in the muscle function, mobility, and it helps in the return of the baseline function of the entire GI tract. Also, provide micro and macronutrients, antioxidants, and it helps to maintain the lean body mass by decreasing muscle and tissue glycosylation. It increases mitochondrial function, and also it increases the protein synthesis in order to meet the metabolic demand of the body. It helps to maintain the gut integrity by decreasing the gut permeability, and it helps in the support of commensal bacteria, because our gut, it consists of a very healthy, important microbiome, and it helps in the stimulation of oral tolerance, and by increasing the butyrate production. It helps in the promotion of insulin sensitivity by decreasing the hyperglycemia, such as in aging. The other benefits of enteral feeding is it helps to attenuate oxidative stress by decreasing the systemic inflammatory response, and it increases the dominance of anti-inflammatory Th2 over pro-inflammatory Th1 responses, and the other benefits is it motivates adhesion molecule to decrease the transendothelial migration of macrophages and neutrophils. These are our innate immunity. and it helps in the it increases the absorptive capacity of the GI tract, and it influences anti-inflammatory responses in the GI tract. It decreases the virulence of pathogens, and it increases motility and contractility of the GI tract. Sorry for the interruption. Um, in patients who have head and neck cancers, these patients, while they're undergoing treatment, they can have dysphagia, that is difficulty in swallowing, and they can have difficulty in oral intake. Hence, these patients also will are indicated for feeding jejunostomy. In cases of gastrointestinal disorders such as gastroparesis, inflammatory bowel disease, short bowel syndrome, these diseases or disorders, it can cause hindrance to normal digestion of the GI tract. As a result, feeding jejunostomy is a good indication. In patients with critical uh, critical care. These patients in long-term, they are in ICUs, and they have undergone long-term fasting, or they are unable to eat. Hence, we go for feeding jejunostomy. In patients who are recovering post-operatively after major abdominal surgeries such as esophageal, gastric, pancreatic, or duodenal resections, they have delayed gastric emptying, or they can also have risk of anastomotic leakage. As a result, feeding jejunostomy can be optioned. And in gastric dysfunction, such as gastric outlet obstruction, patients can have severe gastroesophageal reflux, and in order to prevent high risk of aspiration, jejunostomy can be done. And also, those patients who have undergone previous gastric surgery, they can go for gastric feeding. And in patients with malabsorption syndrome, because they have impaired nutritional absorption, and jejunum is mainly their function is to absorb carbohydrate, nutrients, and fats, and hence, we can always directly put the feed the patient via jejunum. And if the patient, if we try for gastrostomy and we fail, we can go for jejunostomy. So the contraindication of feeding jejunostomy, the absolute contraindication is distal bowel obstruction, because when the bowel is obstructed distally, there is no point of feeding the patient via the jejunostomy, because it will eventually cause swelling of the distal bowel. And in patient, bowel ischemia is also considered as contraindication. And if the patient has peritonitis, the relative contraindications are if the patient has severe intestinal wall edema, radiation enteritis, inflammatory bowel disease, ascites, and severe immunodeficiencies, then we have to, feeding jejunostomy is contraindicated. Uh, there are various techniques of feeding jejunostomy. Either we can go for surgical jejunostomy or percutaneous endoscopic jejunostomy. Uh, in surgical jejunostomy, there are two types of jejunostomy. One is Witzel jejunostomy, and the other is Stam-Catter jejunostomy. So what we do in Witzel jejunostomy is, this is a surgical procedure to create a feeding access to the point in the jejunum, and it involves the creation of a serosal tunnel, which helps in securing the feeding tube. And this prevents in the leakage and the dislodgement of the first tube. So the steps are first in the abdominal wall, after we give patient general anesthesia or either spinal anesthesia, like in the case yesterday, we give a vertical incision. Laparotomy is done, and when we reach into the inside the peritoneum, and from the duodenal jejunal flexor, around 20 to 30 centimeter, we take the jejunum out. And then we create a small. We give a small incision in the jejunum, and then we give a purse string suture, and then insert the feeding tube of around 8 to 12 French, and then we create we create a tunnel by giving us a seromucosal suture, and then we fix the then we fix the tube with the anterior abdominal wall. We fix the tunnel to the anterior abdominal wall so that there's no dislodgement.
Yes, you.
Stamp catheter
No, no,
technique.
no. First poster of the day, you will start with the. No, the next period you minus it.
Yeah.
Sorry,
The post-operative management of feeding jejunostomy. We have to always make sure when to initiate the feeding, and it should be commenced within 24 hours post-surgically. And on the second day of post-operation, second post-operative day, we should start with clear liquid diets or fluids like tea at a low rate, example 30 ml per hour. On day 3, we should gradually progress to around 50 to 50 mixture of tea and the enteral formula that we give to the patient via the jejunostomy, and when to advance to further feeding. When do we advance in order to progress to full strength enteral feeding as the patient tolerates. The aim is to meet the patient's nutritional requirements, and during this process we should monitor if there are any signs of feeding intolerance, such as bloating, diarrhea, or vomiting. When to discontinue feeding. When the patient can maintain adequate oral intake, we can discontinue the jejunostomy feeding, and it occurs around 7 to 10 days post-surgically, and it should be removed if there are no complications. Tube care and maintenance. We should always look for the local skin area where the jejunostomy tube is inserted. Daily, we should apply soap and water for skin care. Flushing should be done with warm water before and after each feeding and medication is given, because this will prevent clogging in the future. And we should always monitor for complications, such as signs of infection, that is redness, swelling, etc. And if there are discharges at or around the insertion site, we should monitor these kinds of complications. And the complications that can occur, it can occur in three groups. It can either be tube related. When after we have inserted the tube, there can be malposition. The tube can displace from its position even after a few days post-operatively. There can be blockage, as I mentioned earlier, due to the clogs, and if there can be breakage or leakage of the from the tube, which can lead to peritonitis, and there can be local complications, and in longer term, granulation tissue formation can occur or local sepsis can occur. In terms of gastrointestinal complication, patient can have diarrhea, bloating, nausea, vomiting, and it is said that up to 30% of patients, they can have diarrhea, bloating, nausea, vomiting, which can compromise the nutritional uptake. Patient can show signs of abdominal cramps and constipation. Uh, uh, the third category of complication is metabolic or biochemical complication disorders, such as electrolyte disorders. Refeeding syndrome can occur. Vitamin, mineral, trace element deficiencies can occur, and there can be drug interactions, and which can lead to failure of the management. Talking about refeeding syndrome can occur in both enteral as well as parenteral artificial nutritional support. And according to uh, we can always assess when the patient can develop refeeding syndrome uh, preoperatively as well, and it can either be one or more of the following. If the patient has BMI less than 16 grams kg per meter square, if the patient has unintentional weight loss of more than 15% within the last 3 to 6 months, if the patient has little or no nutritional intake for more than 10 days, low potassium, phosphate, or magnesium levels prior to feeding. So either if the patient has one or more of them, they can be considered as for having risk of having refeeding syndrome in the future, or two or more of the following. If the patient has BMI less than 18.5 kg per meter square, if the weight loss is unintentionally more than 10% within the last 3 to 6 months, if the patient has little or no nutritional intake for more than 5 days, and history of alcohol abuse or none, or they are on medication including insulin, chemotherapy, antacids, or diuretics. If patient has two or more of the following, then they are also in the risk of developing refeeding syndrome. So refeeding syndrome, they are associated with mainly with hypophosphatemia, because during the refeeding syndrome, we are giving patient nutrition. As a result, ATP generation occurs, and the patient's body uses the phosphate the patient body already has. It is used. As a result, patient undergoes hypophosphatemia, and that will cause exchange of electrolytes from extracellular intracellular compartments. As a result, patient will have hypomagnesemia, hypokalemia, hypocalcemia, um, and have other electrolyte imbalance. Therefore, we should always start patients in order to prevent refeeding syndrome. We should start at least from minimum 10 kilocalorie uh, 10 per hour, and then we can gradually increase per kg, and we should gradually increase by 7 to 10 days to the required amount of calorie that the patient requires, uh, uh, just to prevent refeeding syndrome. These are my references.
Thank you, Dr. Aishwarya.